Hi, this is Peter Glenn Y. Chua, and this is the second part of the first lecture on antibacterial agents. This is prepared for YL6 of the Ateneo de Manila University, the School of Medicine and Public Health. For this part of the lecture, we will be discussing cell wall disruptors, the most important drug class of which are the penicillins. Since its discovery in the early 20th century, penicillins have proven to be an important instrument in the control of bacterial infection. Penicillins have a common backbone, which is 6-amino penicillinic acid. Note that an important part of this backbone is the beta-lactam ring. Notice that on the far left portion of the molecule, you will see a red R, and that R group can be substituted by the various molecules you see on the second column. And the change in R can give rise to the different penicillin varieties that we currently use in the clinics. Note that there is some homologous structure between the two alanines at the end of peptidoglycan molecule and the structure of the penicillin. It is this homology that underlies the effectiveness of penicillins. The variety of the R groups can give rise to the different solubility properties of penicillin. For example, certain penicillins can be taken orally and absorbed effectively, while others are more effective when they are injected or administered parenterally. An example of an oral penicillin would be amoxicillin, while pen G is best taken intramuscularly. Now, penicillins are weak acids. And so, being weak acids, they do not easily cross the cell membrane. And as a result, they are more concentrated outside of the cell than inside of the cell. So, given that same property, you do not expect penicillins to penetrate the eyeball, the prostate, and the central nervous system. For most penicillins, they should be given ideally 1 to 2 hours before or after a meal. That is especially for oral preparations. Most penicillins, in fact, yes, most penicillins, are excreted by the kidneys, 90% through the tubules and about 10% from or through the glomerulus. One particular molecule that is used in the clinics, the drug called probenecid, can raise the blood level of penicillins by preventing the renal release of the molecule. So, probenecid can be used to increase the effectiveness of low dosage penicillins. An important exception would be the penicillin nafcillin, which is excreted in bile, and some isoxazolyl penicillins that can be excreted by both renal and biliary routes. Examples will be provided in the succeeding slides. Take note that in the few subsequent slides, there will be an image of the kidney or the liver on the upper right hand corner, and this is an indication that the drug class is excreted primarily through that organ. And so we go to the part wherein we list examples of penicillins, and Pen-G is the leading example of penicillin and is suitable for many gram-positive bacteria, including meningococci, streptococci, spirochetes, Clostridia, and actinomyces. As mentioned earlier, Pen-G is best given through through a parenteral route, meaning not through the mouth. Pen-G can be mixed with additives like benzathine or procaine that will allow a slower, sustained release that will be more effective in treatment of microbes like spirochetes or gonococci. Penicillin V or penicillin VK, which is pen V in tandem with potassium, is a type of penicillin that can tolerate gastric acids and is therefore administered through the mouth. An important concept that needs to be understood at this point is the concept of beta lactamases. Bacteria produce beta lactamases that destroy the lactam ring of the penicillin backbone. And so if you destroy the lactam ring of the penicillin backbone, you destroy the drug itself. There are some penicillins that are able to resist some beta lactamases. Examples include methicillin, nafcillin, oxacillin, and cloxacillin or dicloxacillin. Note that methicillin is no longer in active clinical use for reasons that we will discuss shortly. Nafcillin and oxacillin and cloxacillin are still in current clinical use. Note that oxacillin and cloxacillin, dicloxacillin as well, can be administered orally, and they are isoxazolyl penicillins, meaning they can be released by the body through both the kidneys and the liver. Particular uh, I'm putting particular emphasis on the usefulness of oxacillin or cloxacillin in the control of staphylococcal skin infections. You will notice this in the clinics that staphylococcal skin infections are very rampant, especially in the communities as you go out of the hospital. Extended spectrum penicillins, including amoxicillin, ampicillin, ticarcillin, and piperacillin, are able to kill a wider range of bacteria beyond the basic gram-positive cocci and spirochetes. They are able to kill certain gram-negative bacteria like E. coli, um, Shigella, and this is because of the variation of the R group that allows them to penetrate the bacterial cell wall, the fur coat, better than your usual penicillins. Note that amoxicillin is administered through the oral route and is therefore one of the most common penicillins prescribed. Ampicillin can be administered orally, but given the molecular structure of ampicillin, it is kind of strange. Why would you give ampicillin orally when it has better bioavailability through the intravenous or intramuscular route? Note that ampicillin has activity against Haemophilus influenza and that amoxicillin is used in the treatment of Helicobacter pylori, a bacteria that is known to cause gastric cancer. An important penicillin would be the piperacillin and ticarcillin because they have pseudomonas coverage, pseudomonas aeruginosa, and they have coverage for particular bacteria that are difficult to treat. These would include your Klebsiella, your Proteus, and Bacteroides species. As we have partly discussed earlier, beta lactamases are an important response of bacteria to survive against antibiotics. And so, in response to beta lactamases, we have identified beta lactamases inhibitors. Note that these beta lactamases inhibitors are in established tandems with penicillins. So these are pairings that have been clinically tested and have been proven to be effective in avoiding or surmounting the beta lactamase enzymes that bacteria possess, and therefore expands the coverage of the penicillin alone. And so, some of the more clinically useful beta lactamase inhibitor and penicillin tandems are first amoxicillin and clavulanate or clavulanic acid. You would know this as the preparation co-amoxiclav. So when you hear co-amoxiclav, you are talking about amoxicillin and clavulanate or clavulanic acid. Another important inhibitor and penicillin combination is ampicillin and sulbactam. And another combination still is piperacillin tazobactam. Now, these tandems are determined, rather, the coverage of these tandems are determined by the penicillins. The inhibitor molecules, the beta lactamase inhibitors, do not increase the coverage of the drug, but rather they make the penicillin more effective against its existing coverage, which would otherwise be limited by the existing resistance of the species. So, I emphasize that these tandems, that these combinations are fixed. It's not a creative pairing that you could do, like for example, with condiments in your house, like you want ketchup and mustard or ketchup and mayo. It doesn't really go that way. Piperacillin is available as a commercial product with tazobactam, and amoxicillin with clavulanate, and ampicillin with sulbactam. So these are fixed combinations. And so we move to another important class of penicillins. Note that these are still a type of beta-lactam molecules. They share the common backbone. And these are cephalosporins. So you can see still that there is a homology, a similarity in the structure of cephalosporins to the D-alanine terminus of your peptidoglycan molecule. And so the effect, the mechanism of action of cephalosporins and your penicillins are the same, if not identical. Note that the R group, as you would have seen in the penicillin backbone, also varies. And the variation of these R groups determine the different varieties of cephalosporins that we see in the clinics. Note that there are two R groups, and the addition of another R group renders cephalosporins an easier time to have an easier time in crossing the cell membrane, because these R groups decrease the polar moment, the polar moiety of your drug. And therefore, the less polar a molecule is, the more likely it is to cross the cell membrane and enter the bacterial cell. So, some of the more commonly used cephalosporins are your cephalexin, cefepime, which is a fourth generation cephalosporin, cefuroxime, you don't see it in the list, but you would have heard of it, ceftriaxone. Those are some of the most popular cephalosporins. Don't worry about not catching those names. You will see them again toward the end of this lecture. So, there is a trend in cephalosporins in that the more recent generations have wider and more clinically useful coverage. In a sense, they become more powerful. The extended spectrum cephalosporins, the more recent generations. But when you come to the fifth generation cephalosporins, an example of which is ceftaroline, there is a certain a shift in the effectiveness of cephalosporins, in the sense that it's not the broadening of the spectrum that becomes important, it is their effect against MRSA, which is methicillin resistant Staphylococcus aureus, MRSA. Now, why is MRSA an important bacteria? Because it is so common and the treatment is very tricky. It is tricky to rid the body of staphylococcal colonization. You need to essentially wash the body with an antiseptic and treat it with antibiotics to make sure that the Staphylococcus aureus do not stick to the hairs, to inside the nose, or to even to the pubic hair or the axillary. MRSA is very tricky to clean from the body. And so, cephalosporins, the fifth generation, are designed to treat that specifically. There are other antibiotics, as you will see later, that are able to handle MRSA, but the list is getting shorter as increasing resistance is observed. As with penicillins, cephalosporins have a common backbone, which is fundamentally a weak acid. This is 7-aminocephalosporanic acid. They are similar to penicillins, but given that they have two R groups on the opposite ends of the backbone, many are stable against beta lactamases. And because of the R groups, cephalosporins are able to penetrate the central nervous system of humans better. And similarly to penicillins, excretion is via the kidneys, with the exception of ceftriaxone and cefoperazone that are primarily released through the liver. Similarly to penicillins, probenecid can be used to increase the effective concentration of the drug in the body. And so, here is a list of some of the more clinically useful cephalosporins and the generations to which they belong. Cefazolin is an important first generation cephalosporin since it is commonly used as a surgical prophylaxis, meaning before you get opened up for an appendectomy or cholecystectomy or some other procedure, you could be given cefazolin intravenously. Cefuroxime acetyl is the oral preparation, while cefuroxime sodium is an intravenous preparation. When you prescribe cefuroxime, and you will, it is a very common drug to be prescribed, please note that cefuroxime acetyl is the oral preparation. And some of the important coverage of the cefuroxime are your Haemophilus influenzae, Moraxella catarrhalis, and your Klebsiella, common agents of pneumonias. For the third generation, we see an expansion of names: cefotaxime, ceftriaxone, ceftazidime. I put emphasis on two particular molecules, ceftazidime and cefoperazone, that have coverage against Pseudomonas aeruginosa. Pseudomonas coverage. And the fact that these are third generation cephalosporins, they have better um, coverage of bacteria that can cause meningitis. And since they have two R groups, cephalosporins in general have two R groups, the ability to cross the cell membrane and through the blood-brain barrier allow the molecules to be effective in controlling bacterial meningitis. Now, the fourth generation cephalosporins, an example of which is cefepime, is suitable for Pseudomonas aeruginosa and some Staphylococcus aureus varieties. But it is not effective against MRSA. Therefore, a fifth generation, ceftaroline would be a leading example, um, addresses that. It may not be able to kill Pseudomonas aeruginosa, but it can treat infections caused by methicillin-resistant Staph aureus, vancomycin-resistant Staph aureus, or linezolid-resistant Staph aureus. Vancomycin and linezolid being some of the more stronger, um, strong antibiotics we use as part of the formulary. Now, I emphasize the adverse reactions for cephalosporins, but the same warning is applied to penicillins, beta-lactams in general. The penicillin backbone and the backbone of cephalosporins has certain homology to molecules that can be naturally found in the body. And when we see um, these molecules bind to human tissues, we can probably create a molecule known as a hapten. Um, or rather, these molecules, cephalosporins and penicillins, are haptens in the sense that if they bind to living molecules, if they bind to human um, polysaccharides or um, polypeptides, they can cause an allergic reaction because the body recognizes the hybrid of the drug and the polysaccharide as a novel molecule, as an antigen. And so we see hypersensitivity, allergic reactions against penicillins, against cephalosporins, against beta-lactam drugs in general. So these would manifest as granulocytopenia, hemolytic anemia, interstitial nephritis. Interstitial nephritis is a reason why cephaloridine is no longer used. And similarly, why um, methicillin is no longer used because it is known to cause adverse reactions which is underlined by a hypersensitivity or allergic response. There is another type of reaction, a disulfiram-like reaction, in which um, drugs with a methyl thiotetrazole ring, example cefotetan, cefoperazone, can induce um, a drunkenness, a drunken-like response, or an exaggerated response to alcohol. So when you are taking these drugs, you would remind the patient to do not consume alcohol because the drunken response as part of drinking alcohol will be amplified so much so that it becomes almost toxic, or if not outright toxic. And also similarly to due to the methylthiotetrazole ring, there can be some bleeding disorders caused by these drugs. And so when you know that cephalosporins or penicillins can cause allergic reaction to your patients, you do not give these, but you do um, a calibrated testing, especially if you're in the hospital, because penicillins and cephalosporins are very, very useful. But then again, the discipline to introduce these drugs to patients is something done perhaps when you have already a specialty, when you are an immunologist or perhaps an infectious disease specialist, in the sense that um, you know how to properly taper increasing dose, and you could have an understanding of how to desensitize patients to certain antigens. To emphasize how hypersensitivity manifests in patients, look at this unfortunate guy. You can see that his eyes are yellow with dead necrotic tissue. His skin has peeled off. His lips are sloughing off. This is exactly the effect of a severe allergic reaction. A severe allergic reaction that is known as either Steven Johnson syndrome or toxic epidermal necrolysis. The difference of which is basically the difference in the surface area of the skin involved. Now, what is dangerous when you see these reactions in your patient is that when you what you see outside, it is also happening inside. It is happening inside the gastrointestinal tract. It is happening inside the respiratory tract. So, up to what extent, we don't know. You could do an x ray or a CT scan, but this dermal reaction, this dermal exfoliation is happening not only on the exoderm, on the ectoderm, on the outside layer of the skin, but also on the endoderm. They're all essentially skin. And it is the formation of haptens that that is part of this very unfortunate allergic response to penicillins. And so we have, at this point, discussed two important classes of penicillins and cephalosporins. Other beta lactams that we will be passing through quite quickly will be monobactams and carbapenems, and some of the other molecules identified in this diagram as well. Carbapenems are extended spectrum beta lactamases in the sense that not only are they effective against gram positives, but very um, they are very effective against Enterobacter, which are largely gram-negative bacteria. Enterobacter meaning they are um, bacteria that grow mainly inside the gut. They are bactericidal in contrast to bacteriostatic. These are carbapenems are bactericidal versus anaerobes, gram not positive or gram negative bacteria, including Pseudomonas. And ertapenem and doripenem are some of the more common carbapenems. Imipenem is notable because it is partnered with cilastatin. It is partnered with cilastatin. The effect of imipenem with cilastatin is that imipenem retains a concentration in the body for a longer period of time. So, since imipenem and carbapenems in general are excreted and neutralized by the kidneys, addition of cilastatin allows imipenem to remain in circulation for a longer period of time, and therefore the activity of the antibiotic is enhanced. Some of the more common reactions to the use of carbapenems are gastrointestinal upset, and they could be administration related, meaning there is some irritation of the blood vessels, especially if it is administered intravenously. And note that on the upper right hand corner you see a kidney, so carbapenems are excreted via the kidneys. Another important beta lactam compound is astreonam. An important um, characteristic of astreonam is that it has no activity against gram-positive bacteria or anaerobes. Astreonam only for gram-negative bacteria. So it is administered intravenously. Similarly, with other beta lactams, um, there can be an allergic response to astreonam, and excretion is through the kidneys. Again, astreonam not for gram-positive bacteria or anaerobes. Now, vancomycin. Notice that the molecule of vancomycin is quite large. And as I have discussed with you earlier, the way that vancomycin neutralizes uh, the cell wall building of bacteria is by wrapping itself or investing in itself onto the D-alanine terminus of peptidoglycans. And because vancomycin is a bulky molecule, it essentially renders further expansion of the cell wall very difficult. It is bactericidal against gram-positive bacteria, including MRSA, MRSA, and Clostridium difficile, however you pronounce that. Clostridium difficile, you will encounter this in the clinics quite common. It is quite common um, reaction to antibiotic treatment. For example, your patient was given erythromycin or quinolone orally, and the patient, after one or two doses, developed diarrhea when there was none before. There is a good chance that the patient had an overpopulation of Clostridium difficile. And Clostridium difficile colitis, C. difficile colitis, is a common adverse reaction to antibiotics. And so, what can you do? But you treat the overpopulation of the bacteria. But then again, current treatment of bacterial overgrowth or an imbalance in the gut flora is also addressed by introducing friendly bacteria to the gut. You will have this lecture with another professor, but in providing probiotics to the gut, you can diminish the requirement of antibiotics and re-establish a friendlier bacterial environment that will be able to resist subsequent administrations of antibiotics. An important adverse reaction for vancomycin is the red man syndrome. Kasi namumula yung pasyente. Akala mo lasing, kung may mga kaklase kayo na kapag nakainom pula, ganong pula as in talagang mapula. Maybe even redder. This is a diffuse vasodilation. It's not clear why vancomycin does this. It's not clearly allergic since these patients that just turn red and they turn very warm and hot to touch, some of them in fact do acquire fever. They do not have difficulty breathing. They could have clear x-rays, and yet they're just red and they are febrile. And then when you discontinue vancomycin, it resolves. So it's one of those weird responses that you see when vancomycin is given to patients. But it does not diminish the utility of vancomycin as a antibacterial controlling MRSA. Another molecule similar to vancomycin is teicoplanin. I haven't really used this, but it is also a bulky molecule. Now, this is an interesting drug, daptomycin. Notice that this is a polypeptide that have more or less a circular structure, and when this drug assembles in the cell membrane of bacteria, they can actually form an ion channel. So essentially, they create holes in the cell membrane of bacteria, and creating these holes in the cell membrane of bacteria disrupts the normal flow of electrolytes. It disrupts the the charge. It disrupts the pressure, the very important osmotic pressure inside the bacterial cell. And so daptomycin essentially weakens the bacterial cell wall, disrupting the normal osmotic environment of bacteria and kills the bacterial cell. Note that this is not effective for gram-negative bacteria, and it is also excreted via the kidneys. Note, for bacitracin, you don't see a liver, you don't see a kidney, but you see a hand because this is a topical drug. Bacitracin is commonly used as an ointment. You apply this on lesions, on wounds, on acne. Um, you don't give this intravenously or even intramuscularly because it's highly nephrotoxic. Highly nephrotoxic. And so you take care that you do not, give this um, inadvertently through a parenteral route, meaning you don't apply this to open broken skin, at least not to wide areas of broken skin. You don't apply this inside the mouth. You don't apply this inside the mucosa, meaning the lips, the genital areas, the perianal areas, the mucosa. You don't apply this in those areas. There are other drugs better suited for that. Another drug, cycloserine. Now, notice that the D-alanine terminus of the peptidoglycan molecule is a very common target. And cycloserine inhibits the formation of the D-alanine moiety in peptidoglycan. And so by preventing the D-alanine from formation, you prevent the expansion, the construction of the peptidoglycan cell wall. Again, this is excreted via the kidneys and cycloserine is administered through the mouth. Oh, important part. This is used as one of those reserve drugs in the treatment of Mycobacterium tuberculosis. And I think this is the last drug for this portion, fosfomycin. Notice that this is a phosphoenol pyruvate structural analog. Um, why does this work? Because phosphoenol pyruvate, as you may see, oh sorry, phosphoenol pyruvate is a precursor in the construction of your peptidoglycan cell wall and um, preventing the use of preventing the construction of your peptidoglycan cell wall is the common mechanism of action for your penicillins. Although structurally fosfomycin is quite different from your penicillins, but is therefore categorized among these. So to have an idea of how a bacterial cell dies, see this video. Alright. See that you see the bacteria, they are expanding as dark objects, and then they turn pale and gray, and you see an ballooning of the bacterial cell. That is what happens to bacterial cells when they are exposed to penicillins. Let me play that again. The bacterial cell expands and then they burst. The bursting represents the loss of the internal osmotic pressure that is necessary to sustain the proliferation and the growth of bacteria, the formation of bacterial colony. And so as the bacterial cell wall is weakened, the ability of the bacterial cell to control growth and to channel the pressure for appropriate growth is lost. And thus the bacteria dies. And that is how your cell wall disruptors kill bacteria. So for the next part, we will be discussing translation inhibitors. And yeah, this is the end of the second part. I'll see you on the next part.